So let's start off just by briefly reviewing the anatomy of the respiratory system. And it, of course, starts with the oropharynx. So you breathe in air, either through the nasal passages or through the mouth. And all of that air goes through the bronchial tubes. So it goes down the trachea and splits off, and where it splits, it becomes the mainstem bronchi. So here's the trachea coming down, and this splits to become the mainstem bronchi going to the left and the right lungs. And then you have, each lung has multiple lobes. So you have 2 on the left and 3 on the right. And then from there, they branch into what seems like infinitely smaller and smaller branches, ending at what? Alveoli, yes. So they branch successively smaller. This is a plastic rendition of the respiratory tree. So have you guys gone to Body Worlds or one of those exhibits before? This is what you'll see there. They inject the plasticine into the airways and then dissolve all of the tissue around it so you get an exact replica of what the airways look like, which is pretty remarkable. Everything here that you see is actually what would be filled with air inside the lung. And all of the rest is tissue. And I'm embarrassed to admit it, but I will admit it. Prior to going to med school, and I didn't have undergrad anatomy, so prior to going to med school, I still kind of thought of the lungs as big balloons, as big air sacs. And I didn't quite get this anatomy until I actually saw it. But the lungs have a very spongy texture. So you can think of all the holes of the sponge as the alveoli and the airways, and then all of the other stuff around it is the parenchyma of the lung. Yes?
So what does it mean that the lungs collapse?
Great question. We will get to that in just a minute. You keep predicting my questions. And for respiratory anatomy, it's really important to be able to look at a chest x-ray. That's the number one tool we have for looking inside the lungs. So on this chest x-ray, here's the trachea, and you can usually see a little bit of translucence where the trachea is because it's such a large airway. Remember with x-ray, what you're looking at, the darker something is, that means the more x-rays pass through it, the less dense that material is. So if there's absolutely no tissue, x-rays will completely pass through and it'll show up as black on the x-ray. So the more dense it is, the more opaque the image becomes. And really what you're looking at is a shadow of the different tissue densities in the area. So here is the collarbone. And all of these are the ribs. What's this? Heart, yes. What's this kind of dense white structure going down the back? The vertebrae. So you don't see the spinal cord that much, but the vertebral column, which collectively we call the spine, is what you see as this dense tissue back here. Down here, what is this? What is this? It's a muscle? Diaphragm, yes. So the base of the rib cage, the base of the lungs, is the diaphragm. That's your primary muscle of inspiration. Yes? That was going to be my next question to you. What do you think it is? So this right here, what do you think that is? It's a really good sign to look for in an x-ray. No. This is normal. Yes?
Is it a hole for your descending aorta?
Oh, good guess. Nope. This is called the stomach bubble. So this is a little bit of air at the top of the stomach. So this person, we can tell from this image, the person is standing up. And the air in the stomach is floated up to the top. Now, if a person is laying down, you won't see the stomach bubble. because it'll be laying at the back. So it's normal, and it's because the stomach tucks right into the diaphragm there. So when we're looking at the chest and we want to see what's going on with somebody, you want to look at these, or they're called the airfields. So this is a normal chest x-ray. You see that the airfields are not very dense, they're not very opaque. And it's normal to see here lung markings. These are the main stem bronchi and the pulmonary vessels, which travel together as they leave the middle of the chest cavity. That's called the mediastinum. So they're leaving that and going into the lungs. So that's what you kind of look for normal chest markings. And then everywhere else should be relatively the same density and relatively dark on X-ray. Another good point to look at, right down here, this is called the diaphragmatic angle. And in a person who's standing upright, if they have any fluid leaking out, and we've talked about a few conditions where you might have fluid leaking out. What's one? Right heart failure. No, but close. Left heart failure. Yeah. So right heart failure will cause congestion in the liver. Left heart failure will cause congestion in the lungs. So some of that fluid that leaks out will pool down here in the diaphragmatic angle. It's called a pleural effusion. So that's something to look for as a sign that somebody might have heart failure or some other thing that's causing increased hydrostatic pressure in the pulmonary vessels. And here, the air's coming down. Here's your pulmonary artery coming down with it. It branches just along all of the bronchioles as they're branching off, and then it ends in the capillary bed here where there's gas exchange. So let's look at the components that make up the parenchyma, the tissue of the lung itself. What types of cells do you expect to see in there? Ooh, you're very specific. Yes, simple squamous type of epithelial cells. And in the lung, does anybody know what that type of epithelial cell is called? What's that?
Alveolar type 1?
They're type 1 pneumocytes. And so your pneumocytes are really the epithelial lining between the air space and the body. Remember, epithelium is a barrier tissue, so in the lungs, the pneumocytes provide that barrier. They're a type of epithelial cell. And they run right next to the capillaries. So if this is the lumen of a capillary, and then these would be the endothelial cells. And here would be the airspace. So if I were to draw this out, this would be an alveoli. So what happens is that you have air in here. When you breathe in, you bring in air that contains about 20% oxygen. Because the partial pressure of oxygen is higher in the air spaces than it is in the blood, that oxygen is just going to diffuse right across the pneumocyte, across the endothelial cell into the blood. Now, this blood has low oxygen and high CO2. The cells of your body have already used up all the oxygen, and then we produce CO2 as a byproduct of metabolism. So there's a lot of CO2 in that blood, and so the CO2 just diffuses across its gradient, so it's going to go the opposite direction, right across that endothelial cell, right across that pneumocyte, and into the airspace. So that's the basics of gas exchange. You're basically crossing these barriers. Now, around here, sometimes you'll have interstitial cells. And I'll show you on histology in just a minute. So these interstitial cells they function to make extracellular matrix. They function like fibroblasts. They really just hold the tissue together. They secrete collagen and elastin, which are the main extracellular fibers in the lungs, and that kind of holds it together. It also provides elastic recoil of the lungs, which we'll talk about in just a minute. You also have some other cells in here, which are your type 2 pneumocytes. What is the function of type 2 pneumocytes?
Secrete surfactant.
Yes, secrete surfactant. And what does surfactant do? So kind of, the mucus that you secrete actually traps dirt and cleanses out the lungs. Yeah.
Keeps the alveoli from
Collapsing in on themselves. Yeah, so surfactant is basically like soap. It breaks up the surface tension of the fluid in the alveoli. So you're secreting mucus and fluid to line that airway to help flush out the lungs. But if you ever get like a drop of water, you know how it tries to make the smallest circumference? So that surface tension of fluid will try to collapse the alveoli, and surfactant breaks it up so that the alveoli can stay expanded. Yes?
So if you get pneumonia, would it be type 2 pneumocytes that get infected, or how does that?
Pneumonia can be, so usually it can be viral or bacteria. So bacteria don't go into the cells. The bacteria kind of live they usually come in through the air space, and the bacteria would live and multiply here. As they secrete enzymes, they'll kill those pneumocytes, and then they can get into the endothelium as well, and they can get into the bloodstream. So that's how bacterial pneumonia would form. Viral pneumonia, they could infect any of the cell types that live in the lungs, but most likely it would be type 1 and type 2 pneumocytes. So both of them can be affected. So let's look at this on histology. All of this space here is air. So this is a very thin slice, cross-section slice through a normal lung, probably out by the periphery because you don't see any big vessels or bronchi. And the cells in here, you can't really see what they are, but it's going to be a mixture of endothelial cells that are forming the capillary walls and the epithelial pneumocytes, so type 1 and type 2 pneumocytes. So you can't tell with any kind of detail in something like this. And then you'll have your interstitium around here. So those interstitial fibroblast type of cells, and a lot of macrophages actually live in the lungs. And so they're going to live in this area here. So this is a bronchiole, this is a vein, and the vein is bigger and more muscular because it's actually coming away from the heart. It's carrying that pressure from the right heart. And the artery is smaller because it doesn't have as high a pressure as it goes back into the heart. Any questions? Everybody have a good feel for the anatomy? Okay. So let's do a little case study. Here's an x-ray for you. We have a 56-year-old man who has ischemic heart disease. He undergoes coronary artery bypass graft surgery. This is a cabbage. I learned about cabbage watching Grey's Anatomy. And so he undergoes cabbage with general anesthesia. 2 days after that surgery, he starts to have difficulty breathing, respiratory difficulty, and decreasing arterial O2 saturation. What does that mean? Medical lingo for not enough oxygen in his blood. Exactly. So he's not breathing well, he's not getting enough oxygen into his blood. Here's what his chest x-ray looks like. So take 2 minutes and just brainstorm what could be causing his respiratory distress. This is a differential diagnosis. There's a lot of things that could be causing it given this clinical picture. So think about some of the things that might be going on here. What we saw here is that this is really opaque, so this is probably air out in that space. A collapsed lung is called atelectasis. It means part or all of the lung collapsed, atelectasis. And there's 3 types of atelectasis. So what you're talking about here is compression atelectasis. So if you pierce the pleural lining, air from the outside world can come in, and it's going to fill up the space around the lung between that pleural lining. And that outside air is going to compress all of the air in the alveoli out of the lung. And that's what the other thing that could go, and so that's one possibility for surgery, is that there was something that happened during the surgery that made him susceptible to pneumothorax. He had a pneumothorax and got compression atelectasis. The other thing that can happen quite commonly after surgery is somebody is lying supine, they're lying in their hospital bed, they're breathing quite shallow. The anesthesia that kind of suppresses the respiratory rate. And so they're not filling their lungs and breathing as fully as normal. Sometimes you get a mucus plug. So that normal mucus that you secrete has to be brought up on a regular basis. So we're all coughing, or the cilia move the mucus up to the surface and then you swallow it. And what happens is if it's not working, the cilia could become non-functional. Sometimes anesthesia can cause that. Sometimes it's just because that person is lying still and not using their lungs very well. They're not breathing very deeply. A mucus plug will plug up that airway. And the air that's behind the mucus plug that's in all those alveoli will gradually diffuse into the surrounding out of that alveoli, and those alveoli and airways behind the mucus plug will collapse. So that's called resorption atelectasis. And we don't know in this patient which one it was. Probably, given all of that air outside and given the extent of the collapse, it wasn't just a mucus plug, it was probably a pneumothorax. Yes?
Can I ask a question about the picture?
Yeah, of course. Okay, so we've talked about compression atelectasis, we've talked about resorption atelectasis, and then the third type is called contraction atelectasis. So this occurs where there's something in the lung tissue itself that won't allow it to expand. And one of the biggest causes of contraction atelectasis is something called ARDS, acute respiratory distress syndrome. And the reason it causes atelectasis is that there's a loss of surfactant. So acute respiratory distress syndrome, it happens very fast, and it usually happens after some kind of traumatic injury. The one I can think of most common is drowning. So somebody who's a drowning victim, they get water into their lungs. The water washes that surfactant. It causes a reaction in the lungs to foreign substance. And so you get widespread inflammation. That inflammation disrupts the type 2 pneumocytes, and you can't produce more surfactant. Causes the lungs to collapse because the loss of surfactant. You can also get loss of surfactant in newborns. If babies are born before type 2 pneumocytes are mature, then they can't produce enough surfactant, and their lungs won't expand after birth. So the baby's first breath, the lungs are supposed to fully expand. If those pneumocytes are immature, that won't happen, and the baby will have respiratory distress and has to be put on a ventilator. So that's why when you see premature babies, really premature babies on a ventilator, it's because they don't have enough surfactant yet to maintain their airways open. Okay, so those are all the causes of atelectasis. And why does it cause respiratory distress? Basically, it's a loss of ventilation. So there's two things, whenever you're thinking about pathophysiology in the lungs, you think about ventilation and perfusion. So is there adequate ventilation? Is there adequate air coming into the lungs? And is there adequate perfusion? Is there adequate blood coming in? Because remember, you need gas exchange between the air spaces and the capillaries. So you're looking at ventilation and perfusion. And ideally, ventilation and perfusion are matched. Everywhere in the lungs, there's air, and everywhere in the lungs, there's blood. In atelectasis, even partial atelectasis, wherever that ventilation has been lost, you get perfusion. The blood is still coming to that area, but there's no air in the area. So it's a ventilation-perfusion mismatch. There's lots of kinds of ventilation-perfusion mismatch, where in this case you have perfusion without ventilation. The clinical term for that is a shunt, because the blood comes looking for new oxygen. There is none, and it just goes right back to the heart without gas exchange. It's shunted past that area. So what do you think are the clinical manifestations? Oh, Ian, sorry.
That was going to be my follow-up. Would you find hyperventilation as the clinical manifestation?
So you will get, increased respiratory rate. And we'll get to the terminology in a minute. Hyperventilation, it may be hyperventilation, but hyperventilation really refers to when you have ventilation beyond what's needed for adequate gas exchange. So in this case, because they actually need to increase the respiratory rate to get adequate gas exchange, you wouldn't call it hyperventilation. But it is increased respiratory rate to make up for that loss of gas exchange in one part of the lung. And breathing is a really interesting thing. People will just say, it doesn't hurt, it's just hard to breathe. Has anybody had that? Especially if you've had asthma. People with asthma know what this feels like. It's just hard to breathe, and it's hard to describe. And we call that dyspnea. It's not necessarily that they feel that they're breathing too fast or too slow. They don't feel like it hurts. it's just hard to breathe. They feel like they're not getting enough air into their lungs. And then yes?
What about spontaneous pneumothorax? Would that be considered, or the cause would be premature too?
So a spontaneous pneumothorax can happen in anyone of any age. And usually it happens just because there's a structural defect of the pleura. And sometimes they call it a bleb. And sometimes just it can happen randomly or it can happen with trauma. It'll rupture. So this little bleb, you can kind of think of, if you get like a plastic cup or something and there's a little structural defect in it and maybe it gets a hole in it, like your Starbucks cup. It doesn't happen often, but once in a while it happens. Something went wrong in the development process. Most people with a spontaneous pneumothorax, you put in a needle, you let the air out, and it just heals over. And it's actually probably a lot of people experience small pneumothoraxes, and they never know it. The air will eventually they may feel like they're having trouble breathing. They think they have a little bout of asthma, or they think they have a little cold or something. The air gets resorbed and the lungs re-expand, everything heals up, and you may not even come to medical attention. So it can happen to anybody. Okay, so the last thing, what happens with increased respiratory rate? You're increasing your respiratory rate to try to get more oxygen in the blood. And as you do that, you actually end up getting rid of, or you're not able to get rid of all of your carbon dioxide, right? You're not able to get enough oxygen in, and you're not able to get enough carbon dioxide out. So I think that is what we mean here by hypercapnia. So not enough CO2. You can't breathe out enough CO2. Anybody know why that would be dangerous? Yes. So CO2, well, how is CO2 carried in the blood?
Carbonic acid.
As carbonic acid, HCO3. And so that's one of the ways that your body maintains acid balance. And if you end up not being able to get rid of enough carbon dioxide, your blood becomes acidic. And we all know all of our proteins have to function within a narrow pH range. So you try to compensate by excreting more acid through the kidneys, but the kidneys work much slower than your respiratory rate. Okay, so I already mentioned dyspnea. It's hard to describe, but it's just basically difficulty breathing. And then I was trying to get a little bit into this idea of hyper and hypoventilation. Hyper and hypoventilation means that you are increasing respiratory rate or decreasing your respiratory rate beyond what is needed for normal gas exchange. So by definition, if you hyperventilate, you're breathing off, you're getting rid of more CO2 than you need to, and so you become hypocapnic, and you're losing acid. You become alkalotic. It's called respiratory alkalosis. This is more detail than you need. I'm just trying to show you how it all fits together. So this will lead to respiratory alkalosis. With hypoventilation, you're retaining CO2. You're not breathing off as much CO2 as you need to, and that's going to lead to a respiratory acidosis. But again, this idea of hyper and hypoventilation, it's a change in respiratory rate relative to what you need for normal gas exchange. So you can't define it by a respiratory rate above 100 because it really depends on what's the underlying physiology in that person. Yes?
Would it be alkalosis for hyperventilation?
Alkalosis. So with hyperventilation, you're breathing so fast, you're getting rid of too much carbon dioxide. So as you breathe off carbon dioxide, you're getting rid of acid. So that bicarbonate forms water and CO2. The CO2 leaves the body, leaving water behind. So you actually get rid of acid in that equation. You get an alkalosis. Does that make sense? Cyanosis? What is that? Turning blue. Right, so cyanosis is a clinical sign of hypoxemia. You turn blue when you don't have enough oxygen in the blood. Hypoxemia just means not enough oxygen in the blood, low blood oxygen. And that you can quantify. And then hemoptysis is really when we get into pneumonia, we'll talk about it more, but that's coughing up blood. It's not a good sign. Okay, missed the break today, sorry. Yes?
Why would you be coughing up blood if you're above blood?
No, you won't get hemoptysis with atelectasis.
Oh, okay.
When we get to pneumonia, we'll talk more about it. With pneumonia, you'll get hemoptysis sometimes if there's enough destruction of the parenchyma of the lungs. Yes?
With coughing up blood, should you be worried if you have a blood after a bloody nose? Because isn't that kind of like...
That's a great point. So if somebody comes in and says, I'm coughing up blood, you have to figure out where that blood is coming from. Because most of the time when people are coughing up blood, the blood is actually coming from somewhere up here. So it's coming from something in the oral pharynx, often a bloody nose. People will think they're coughing up blood when it's actually coming up the esophagus and it's coming from the GI tract. So somebody who maybe has a little bit of esophageal varices and they're leaking blood, they might say, I'm coughing up blood, but really it's coming from the esophagus. So it's important to be able to see that. A good sign, or not a good sign, but if you see blood in mucus, in like a really, that thick, gross mucus that you get when you have bronchitis, if you see blood mixed in with that, then it probably did come from inside the lungs. If it's mixed with saliva, it's probably more superficial in the air system. Okay, so before we get into the rest of the pathology, and I know I'm going pretty slow, but it's fun too, so we're going to review respiratory physiology. And I know you guys have had this, so we'll just do this really quick. You're sitting there, breathing normal. The volume of air, if we were to measure how much air is coming in and out, that's called your tidal volume. So when you're just sitting, breathing normal, you're not trying, the amount of air that you inspire and expire is your tidal volume. Now, I want everybody to start taking deep breaths. Breathe in as much as you can and breathe out as much as you can. So what you're doing now is you have an inspiratory reserve from when you just were sitting there to when you're trying to breathe really deep. I can breathe in a lot more than I needed to. That's inspiratory reserve. And then if I say exhale as much as you can really squeeze a lot of air out. That's your expiratory reserve right there. Does everybody feel like you have good inspiratory reserve and expiratory reserve? Not so much. So when you ask somebody to breathe as deep as they can, breathe in as much as you can and breathe out as much as you can, that measurement is called their vital capacity. So that is a measure of how much inspiratory reserve and expiratory reserve they have. Usually it's much, much greater than the tidal volume. And because we don't want our lungs to fully collapse and we have surfactant, you never can exhale all of your air. Even the best yogis who can really have big vital capacity, they still have some residual volume. So the amount of air left in your lungs when you've exhaled as much as you possibly can is your residual volume. So total lung capacity is your vital capacity, that's all of your inspiratory and expiratory reserve together, plus the residual volume. Often it's very hard to measure residual volume. Usually we just estimate it based on a person's height and weight, or height and gender, to get the average residual volume. And then we can estimate total lung capacity by just adding that to what we record as a vital capacity. So just help you think about all of this. Think about this question. You have a person whose total lung capacity is 5,000 mils. It's a nice normal lung capacity. When he was 25, he had a vital capacity of 4,000. Since then, he's gained some weight. He's gained 100 pounds over the past 5 years, and his vital capacity is now 3,000 mils. No other respiratory problems. So, which other lung volume? We know that his vital capacity has changed. Which other lung volume or volumes do you think would change along with that? I mean, have you talk with your neighbor to figure it out?